Can you hear us? Good afternoon. Thank you. Good afternoon to all. Happy to see you all. As ma'am said, today we are going to learn about pain. Last week we learned about introduction to palliative care, what is palliative care, and also we learned the importance of the aims of palliative care, to improve the quality of life of the patient, and the second most important aim is to relieve pain and other symptoms. So pain management, the symptom control is one of the important thing in palliative care. So we are here to learn about pain. We have Mr. Sudeep with us. He is a palliative care nurse and he did his MSc nursing in oncology, and he was working as a palliative care nurse at Dr. B. Baruch Cancer Institute, Guwahati. And also he was working as a nurse educator at Cipla Palliative Care Training Center, Pune. Currently working as a LNAC trainer. He has more than 8 years of experience in palliative care. So welcome, Sudeep, and over to you.
Okay. Good afternoon, all. It's a disclaimer that I'm having some issue with my laptop. So, of course, if you have anything, you can write in the chat box. So, you can write in the chat box, and then after the session, like there will be 20 to 30 minutes of didactic session, and after that we can go through the query section if you have any query regarding the didactic section, and followed by there will be case-based discussion, I hope. Yes, Shiva?
Yes.
Okay, so can I have my PPTs? Yes. So like the first page, please go to the first page. Okay. Yes. Previous one. Where is my names and all those things is written? Okay. So before going to the actual session, I like to ask to the participants, what do you think that when somebody is, and I think every one of we have experienced pain and sometimes in our life. So if somebody is like some patient is telling to you that he or she is suffering from pain, what do you think? So you can write in the chat box. Shiva, you can tell me what they are writing.
Yes. I get. Please put your answers in the chat box.
Try to reduce. No, if somebody asks you that I am suffering from pain, so what do you think actually? What is your first thought come to your mind?
One of Rajesh Kumar said uneasy feeling.
Okay. Yes, you are partially correct, of course. And then I can see Kushum has written
yes.
Pain has physical, mental, and psychological components. Yes, Kushum.
Any other answers?
Okay, so my next unpleasant feeling. Okay. So followed by my next question to the group. Okay, if somebody is telling to you that I'm suffering from pain and you are the nurse on duty that you have to like assess the pain. So what are the things you are going to ask to your patient? Where is pain from when? Who has bus and scale to assess his currently emotional feelings? Okay. So I hope some of them, they have already attended some of the sessions and they have very good, nice concept actually. So without wasting the time, let's move. So next, please. So if we see that what is the definition of pain? Yes, please. Next, please. Next. Yes, just stop. Okay, so ISP and IASP, Indian Association of Study of Pain, IASP has given the definition that pain is an unpleasant sensory and emotional experience associated with actual and potential tissue damage, and it is not mandatory always to have that some tissue damage. So sometimes what happened that like unexpectedly somebody has scolded me, so I feel so painful that I like that person, but that person has scolded me without any reason. So this can be a like it is also a kind of pain. So all together, next please. Next please. Yes, next. Okay. So all together, Dr. Robert Troy-Cross, who is the professor of Oxford University, he said that pain is what the patient says that it hurts. It can be hurt, it can hurt in any like any way. So it is not mandatory always to have the physical pain. Sometimes psychological, like those patients, and I think in the introductory class it had already been mentioned that palliative care is something which deal with the chronic illness patients, and whenever patients are dealing with some chronic illness and chronically they are ill, so some psychological things and psychological aspects come to their mind. It's like why I'm here, like anxiety that they cannot go to their work and they cannot support their family members, this kind of things, and they cannot express those things to their family members. So this anxiety, depression related to pain, these aspects come. Sometimes what when the patient is chronically ill, so their family members and their friend circle also, if they ask, okay, can you please go with me to market for shopping? So he said, no, I am having some pain. Okay, second day, maybe after few days, again they ask that, okay, do you want to go with us? We are going for shopping, or we are going to for movie. Then they are not willing because they are having pain. And on the third day, actually they are not having pain, but their family members will say, no, he is always pain. Okay, no need to ask. Okay, let's go. And when he come to know that my family members and like my friends, they went for shopping or movie without asking me, but today there is no pain, but I wanted to. So they feels isolated. So this is like psychology, like social kinds, like social aspects of pain, and some pre-existing things come to their mind. It's like why I am, what sin I have did, and why it is only happening to me, and these kind of things, this pre-existing, but always we do not have the answer, but uh, it's happened to the patient. So it's like spiritual things. So these are the four aspects of pain, and it's all together, it hurts the patient. Next please. So if we see the incident, so first incident, like pain and advanced cancer are not synonymous. 3/4 of the patient experience. Yes. Can you please put your mic in mute? Okay. So, and then most cancer patient has more than one type of pain, because gradually it starts with the nociceptive pain in particular place, and gradually the nerve involvement happens. So there is nociceptive, neuropathic, both kinds of pains basically patient experience. And the 15% of the patient, no metastasis patient, also have pain due to other illness. And the present and some patients who they are surviving, actually they are surviving and they are undergoing any of the treatment, and some patients, they are having pain related to treatment and in the survival stage. Next please. This is the incidence actually. So pain versus suffering. So now one question and again one question to my group, that how many of you think that if there is pain, so that means the patient is suffering? How many of you think that it yes, and how many of you think that no? Please write in the chat box. Yes. Yes. There is no. Okay. 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 So like every one of you, maximum of you are feeling like, okay, pain means the patient is suffering. Now I have a question for you. You see the first picture, the lady is having tattoo. Okay, see her face. Do you think that she is suffering? She is enjoying. Of course, she is suffering. Making tattoo is a painful procedure, but she is not suffering. She is enjoying. But because after 2-3 days, it will enhance her beauty. So by thinking that, she is enjoying that. Okay, now I am having pain, but I'm not suffering. Look at the second picture. The patient, we always give catheter. It's painful, but patient do not suffer in that, because there is some good intentions. Because patient feels that, okay, after few days I will be good, so they do not suffer. They, of course, they feel pain, but it's not suffer. But look at the third picture. Nobody is doing anything to her, but she is feeling like isolated. In her mind, maybe so many things going on, and so her family members, her near and dear one, maybe not talking to her. So these are the things make the patients more suffering. So in the chronic illness patients, these are the things happen. What the last picture is showing. So it is not mandatory that every pain is suffering, but every suffering is painful. So we, as a palliative care team, our main goal is to reduce the suffering. Next, please. Next, please. Okay. So, like Betty Farrell said, Betty Farrell is someone in USA. So she said that if we cannot assess the pain, we cannot address the pain. Of course, if some of your senior member, they are asking you to do some work. If they are not asking you what to do, then you cannot perform the work. Firstly, you have to understand what I need to do. So assessment is very important. And so like nurses as a professional caregiver, they need to assess, and they are the eyes of doctor. Doctor are not there in the ward for 24/7. So they are work like the eyes of the doctor. So they give information to the doctor and report with the family members, so that they take the leadership and also advocacy, take the advocacy for the patient issue to the doctors, and guide the management how to do how to handle the family, and what are the different issues and things going on with that family and the patient. And of course, they need to determine how frequently the pain assessment need to done. Next, please. Yes. Why is pain not betterly managed? If we see that, sometimes patient feels that if I continuously say that I'm having pain, then my family members and all other friends, they will think that I am weak. So I don't want to show that I am weak. If sometimes they feel that, okay, if I continuously tell that no, I'm having pain, and if I'm taking continuously SOS dose of pain, so it seems like I'm drug seeking, but I don't want to show that. Next, please. Another line is there. Yes. Think their pain is not believed. So sometimes they feel that no, every time I go, doctor give me the no, your face is not like that, you are having pain. So he himself give the close-handed questions, that it seems like I'm like telling lie to the doctor, so I'm not believable person. So if I continuously telling that I'm having pain, there is no point. So by that time, they are not complaining at all. So this kind of patients, like it's very difficult to manage their pain because they are not coming to the focus. Okay, next please. There are yes, so if we see the barriers of pain relief, there are 4 kinds of barriers. Sometimes like barriers like healthcare provider related. Maybe the healthcare provider do not want to go for the repeated pain assessment because it's like increases their workload, so they don't want to increase their workload. If the hospital is NABH, JBL, whatever it's accredited, of course they need to assess the pain as a 5th vital signs, but they maintain, okay, see this patient is laughing, that means he is not having pain, let's write no pain, or maybe 0/10 or 1/10, whatever it is. So they maintain, if you see the paperwork, they are maintaining, but exactly they are not doing the pain assessment because they feels that if I keep on asking each and every patient, it will increase my workload. So, and also one thing, sometimes the healthcare personnel, they are not that skillful enough to assess the pain. If we see the system related, healthcare system related, like junior nurses, they are working, so they need to inform their senior will inform the resident doctor will inform the maybe assistant professor, they're next to the professor, and professor is busy with some meeting, so assistant professor will, no, I cannot talk to my professor right now because he is busy. He is busy, okay, but the patient is suffering. So because of the healthcare system related barrier, sometimes the patient suffer. If we see the patient and family related barrier, sometimes the patient feel that, okay, if I'm like I told I have gone to them so many doctors. They have changed so many medicines, but still I am having pain. So that means doctor is a doctor. He is a human being after all. He is not a god. So if I keep on saying what he will do, he has also some limitations. So patient himself think like that, and also sometimes family member, they will feel that see when I was sitting with him, he was telling that he is human being, he is a human being. I just went out and see he is laughing with the mobile phone. He is doing drama. He is not having pain at all. So these family members give us the misleading, misdirection. So these are the one of the barrier. And lastly, the policy on law related. Maybe the hospital has no policy or like no policy for the like next level drugs, like every hospital they use the weak opioid, but they do not, every hospital do not have the license for the strong opioid, and doctors and the healthcare workers also not trained enough to handling those drugs. So policy related barriers are there. Next please. Next, yes, if we see that what are the patient who are in the risks to under treatment, like who the patient who deny pain, who speaks different language that we cannot understand, and sometimes the culture that, okay, they don't want to tell when there is some good news day, good day is there, like celebrating maybe in case of like Christmas, it's Christmas day, so I cannot tell that on that day that I'm having pain, next day I'll tell. So they may skip, they are skipping, I don't want to give trouble to my family members. Okay, sometimes nonverbal or cognitively impaired patient, so we have to assess their pain through behavior, and behavior is something that somebody is paying small pain also giving the most like high response, so they are showing that it's so painful, but sometimes the patient already was pain for a very long time, so a little bit pain is not a like moderate, mild to moderate pain he can like go with, but he is not showing in his behavior. So if we see that non-verbal or cognitively impaired patient, so this may mislead to us. Sometimes the children's or older adults, so they cannot express, their language is not so clear, and sometimes the patient who has the addictive disease. Okay, let next please. Yes, so if we see that 80 to 90% of the patient can pain relief for the 80 to 90% patient is possible. When acceptable pain relief is most of the cases, it's possible. However, we have to keep on reassessing the things and readjustment the things, because sometimes it's difficult to treat the underlying causes. So we are just covering the symptoms. So whenever the cause is there, so symptoms may come every now and then. So we have to keep on reassessing, and as per the severity of the symptoms, we have to adjust the doses of the medicines and other things. Okay, next please. If we see the pathophysiology of the pain, so I'll just give you a touch, because pathophysiology is something it itself can require maybe 1 or 2 hours class. So I'll just give you, it's an efferent pathway, central nervous system, and efferent pathway. So through the central nervous system, from the efferent pathway, it takes the responses, and through spinal cord, it's go to the brain, and brain itself recognize that what kind of motor activity is required. On the basis of that, body shows that motor activity. So just remember that efferent pathway, central nervous system, and efferent pathway. Most likely, the next please, if we see the next. So yes, central sensitization is something that we need to recognize. Just imagine some of you are employee, and your boss is asked that you need to give a presentation in a seminar. So tomorrow is seminar, and today he is telling that no, you are making the wrong PPT. Okay, so you have to make that PPT, which is not even a 72 hours work. It's more than that. Do you are you going to do that? Of course, no. So one or two employee may think that no, we'll say our boss that it's not possible. Okay, then they will think that no, if one or two of we will go to our boss, the boss will directly take us in a gunpoint and kick us out. So let's make a group. Through group, we will go to our boss that it's not possible. So the pain does the same thing. Okay, so first thing it happens that okay, it's paining right here, but gradually if it is not unresponsible, I'm not doing, or my body is not taking any action against it, so it starts recruiting the surrounding cells. So it says like okay, all of we togetherly will make it possible. So they will so patient maximum time it will like they will complain like okay, I'm having pain right here, but gradually when the pain increases, my whole shoulder to the down and like my limbs, everything pains, even I can't recognize where is the pain exactly. So this kind of centrally sensitization, so it recruit the other cells as well to make the body responses. Next please. Okay, if we see the types of pain, of course, according to the duration, there is the acute pain and chronic pain. But we are dealing with chronically illnesses patients, so we will discuss the chronic pain more. Next slide. If we see the chronic pain, there are nociceptive pain and neuropathic pain.
Right now,
Yeah.
we lost you.
Oh. So till how long? Somatic and visceral. Okay, so somatic pain, it's like related to the like body cells or maybe tissues, normal tissues, covering tissues, maybe bone tissues, bony tissues, and the muscle tissues. But visceral is related to the organ. It's maybe liver, bowel, and cardiac. So it's all related to the bowel. Maybe maybe the cholecystectomy patient, they feel really in the right hypochondriac region, so it is more likely to be visceral pain. Whereas if you are having some cut in the finger, so it's likely to be somatic pain, it's the covering tissue injury. Whereas neuropathic pain, neuro means nerve, pathy means damage related to nerve damage. It can be like with the diabetes mellitus, it can be any cancer related treatment, maybe post chemotherapy, post radiotherapy, or maybe surgery, or maybe other drug. The patient is having taking some drugs. Request all the participants, can you please mute yourself? Yeah. So we are talking about the pain, neuropathic pain. So neuropathic pain can be related to the medications. Maybe the patient is taking some medications which can cause neuropathy. So followed by that, the patient may suffer the neuropathic pain. Next, please. Well, I was talking about the physical, psychological, social, and spiritual aspects. All these four aspects, it was very essential to maintain in palliative care. And all those four aspects combinedly told the total concept of pain. Okay. So whenever we will deal of the any of the palliative care patients, we have to think from that four aspects especially. And if the patient is not suffering not only the physical pain, we have to see if the patient is suffering from any of the other three aspects like psychological, social, and spiritual. Okay, next please. If we see the etiology of pain, it can be tissue infiltration related, maybe like arthritis or any of the secondary disease, maybe treatment related like surgery, chemotherapy, radiation, what I have told, like those things, surgery, chemotherapy, they do the tissue damage or maybe the nerve damage, and followed by that the patient can develop pain, and maybe sometimes debility related like pressure sore, constipation, bladder spasm, and all those things. Next please. Yeah, evaluation of pain. So different centers use the different things. Some of the centers they use the old card, some of the centers they use the OPQRST, some of the centers they use the only PQRST. So different like style, but of course every one of we are in the same page. If we see that pain history can be taken in PQRST format, so it's basically OPQRST. O means onset, since when the patient is suffering from pain. P means next, please. You just do next. Yes. So if we see that P means palliative and provocative factor, which makes the pain better and which makes the pain worse. If we see the Q, Q is the quality, what type of pain the patient is suffering from. It may be burning pain, it may be shooting pain, sometimes it may be throbbing type of pain, sometimes it may be like what to say, tingling pain. So the quality of pain gives that what are the like what exactly the treatment required for that particular patient, maybe pharmacological, maybe non-pharmacological. So it's give an idea that what are the things can be the possible things and like uh, maybe the causing factor for this pain. And R means radiation, whether the pain goes from one part to another part. So if there is neuropathic component, so basically patients give you that history that yeah, it starts rightly from my backside, but gradually it goes down to my lower extremities. So this kind of radiation from one part to another part, radiation of pain history is there or not. S means severity. Of course, we use some scales in different institutes. So all the scales give us that how severe the pain is suffering, the patient is suffering from pain. So severity, it's like we have to use that scales and we have to give that how severe the patient is suffering from pain. T means there are temporal factor, maybe treatment, maybe other things. So tempo and timing. Temporal factors means like incidental pain. Sometimes patients said that no, doctor, whatever the medicine you have given, it's really working for me. But sometimes no, when I try to get it from my bed in early morning, I feel pain. This is the incidental pain. This is the temporal factor. Okay. Sometimes patient feels that no, every evening, no, I feel pain. Or maybe every morning I feel pain. Sometimes the patient says that, okay, and in this T, we have to take the history of previous medication. What are the previous medication the patient was taking? Okay, next please. Next. Yes. So pain is, if we we have seen that total pain concept. So pain is not only that physical things, but also it's the anger, anxiety, depression, and all the things, isolation, all things combinedly influence the pain. So we need a team who can assess the pain from all the aspects, and nurses, of course nurses can assess, but nurses need help from the other aspects. That nurse cannot be a psychologist every time, nurse cannot be a MSW every time, nurses cannot be a like spiritual agent every time. So in such conditions, no, like we need to help our interdisciplinary team, and role of pain counseling from the interdisciplinary teams comes in such conditions whenever we try to address the total pain. Next please. Okay, so we have to depend on the biopsychosocial. Okay, bio means related to medicine, psychosocial of course by the counselor and all those things. So all of we need to take the help from multidisciplinary team to address the patient's pain effectively. Next please. Now there are some scales. It's like randomly wise I have given, like visual analog scale, maybe numerical rating scale, faces scale, and these are the scales that every hospitals they use. But of course we need to use the appropriate scales for the appropriate age groups, otherwise it will give us a wrong like wrong result, and as a result we cannot address the patient's pain effectively. Okay, next please. Okay, if we see the principles of pain management, let's see the little bit of that. So the nurse need to give the medication by the clock, by the WHO analgesic ladder, and also by the appropriate route and by the class. And attending the details means what are the things the patient is not telling to us, the nurse has to take all the things consideration. Maybe maybe the doctor is not, maybe the patient is not telling to the doctor that yesterday there was Eid, and sorry, Ramzan, and I was fasting, and you told me that I have to take my pain medication after my after meal. No, on that day I was not taking meal. How I can take the pain medication? The patient may not taking the pain medication. So these are the things that attending the details. What are the background of that pain? We have to take in the considerations. Next. WHO analgesic ladder. This is the ladder which basically help us to manage the physical concept of pain, but other psychological, social, and spiritual we can address most of the time with proper counseling. So in that WHO analgesic ladder, we have the 4 steps. Step 1, it's a non-opioid class, maybe paracetamol, ibuprofen, and all kind of NSAID. This comes step 1. If we see the step 2, this is the name of weak opioid, and in the weak opioid we have 2-3 drugs like tramadol, tapentadol, codeine, oxycodone, all. Step 3, it's the strong opioid, basically used for the severe to severe pain, and it's the opioid class like morphine, fentanyl, buprenorphine, methadone. All of the things come under step 3. There are step 4 also, but step 4 is not applicable for all the patient, because step 4 is the interventional pain management, and for that step 4 the patient has to have some like what to say, patient has to have some physical fitness, and if there is no fitness it's not applicable. So step 4 is the interventional pain management, and it can be used with any of the steps. Okay, so it's all about like brief about the WHO analgesic ladder. Please go through. Next please. So by the class means whenever there is like non-opioid can be used with opioid, but 2 opioids cannot use at a time. And so, and as a nurse we need to keep those things very very positively, that okay, doctor, we have sent the patient in the OPD or maybe other pain and palliative care department. So what class of medication? Sometimes what happened, the patient was taking tramadol tablet, it was not effective, doctor has given, okay, please start the injection tramadol for 2 days. By that time nurses forgot to tell him or her that okay, don't take the oral medications. Here the patient is getting the injections as well as the patient is taking the oral medication. So these are the things we need to very effectively we need to keep in mind and teach the family members so that this medication error should not happen. Next. By the mouth, oral route is the preferable route, but of course it depends on the patient condition, and on the depend on that we can we can we can administer the medication through subcutaneous, intravenous, transdermal, transbuccal mucosa, and maybe transnasal, epidural, intrathecal, and nebulized. But all of the facilities may not be available in all the setups, but depend on your setups. These are the other routes that, of course, the pain medications can be administered. Next, please. Attention to the details that, of course, there are some correctables. What is the patient is not maintaining, or patient was not given the information properly, so the correct need to be correctables. And non-drugs things, some of the maybe non-pharmacological things we need to teach the patient and the family members, so that it should increase the efficacy of the drugs, primary drug. Next, please. Okay, so medication, chemotherapy, all the things should help, but there should be some non-pharmacological relaxation therapy, aroma, hypnosis, massage, acupuncture, and meditation, of course. But it depends on of course, your patient. So, like, patient is having severe pain. If you ask your patient to listen the music, he will kick you out. So it depends on in which level the patient is suffering from pain. And if the patient's always the patient pain is like it's patient is comfortable, or patient can live his life with the pain, but there is little pain, so we can just try different therapy or other diversional activity or diversional therapy to divert his mind in some extent and see how it is effective. It is not effective, of course we need to change. Next, please. Responsibility of the nurse, like accurate assessment and documentation, of course, reporting and emergent the management of pain if there is severe pain, and documentation of any unwanted events in between. And of course, communication. It is not only the communication to the doctor, it's communication to the family, to the doctor, and to the whole team itself. So whatever the plan is going on in your shift, it should be conveyed to the next shifts as well. Next, please. So next. Shiva, am I running out of time?
No.
Okay. So reporting, of course, in the reporting time, every time, I don't know about the others, but sometimes it happens in Indian scenario that nurses are report to the pain, but not in the sequence manner. So we have to address the thing and we have to report to our physician with appropriate skills, appropriate manner, and appropriate way, so that the physician will get an idea about the patient. So, and it's really helpful for our nurses and patient. It will also help the nurses to get the or maybe develop the rapport with the patient family. Next, please. Okay. So emergent pain management of pain. So first point of call until the physician arrives, it's the nurse. Non-pharmacological management, of course, you can start that give the reassurance that if you think that, of course, it's effective and okay, we can manage, and determining when the determining like when to administer the analgesics. The analgesics dose and like rote and everything, all of we need to be very confident enough. And whenever the patient family members came to ask us anything, all of we should give the same answer to them. And evaluating the effectiveness of analgesics, so that reassessment, of course we need to do reassessment. Like everyone, like if you give any exam, like if you are doing any course, there is evaluation to reassess how there is how much your improvement is. So all of we need to take it challenge, and all of we need to do the reassessment to see how much we have done effectively our job. If not, then we need to replan, of course. Next. Documentation. Without documentation, nothing is happened, because every one of we busy with maybe we are busy with our job, of course, but we spend a lot of time with our family. We give, all of we give like 6 to 8 hours a day with our job, but another maybe 16 hours we are giving with our families. So we have so many tensions to take. But if somebody is on leave, so you cannot ask the person who is on leave that what you did before. So as the nurses are providing services 24 into 7, so we need to maintain a proper documentation, so that it's give a clear picture to our next shift person, and he or she does not need to worry about that. And whatever we did and whatever the discussion was done, all the things should be written properly, so that if the same thing, because patient sometimes they cross check with the another nurse, okay, let me check if she has any other options for my patient. So they keep on asking the shifting, if shift change, the same thing they will ask the 3 shift nurses as well, whether they get the same answer or not. So we need to be in same page, so that we can give the same answer to them, and they should not be misleaded or misguided. Next, please. Okay, so let's come to the side effects. All of we are very worried about the side effects of opioids. So these are some effects, but what are the effects is unexpectedly come. It's called side effect. So see this in the form of sacrum. S means sedation. All of we know that drowsiness happens whenever there is high dose of opioids we give. So sedation or drowsiness. The S means sedation or drowsiness. A means analgesia. Of course, we are giving any kind of medication to get the analgesic effect. But suppose the patient came to your OPD first time, and you assess the patient is having 6 out of 10 in numerical rating scale. So you want his pain supposed to be reduced up to 3 out of 10 in numerical rating scale, and you have given first starting dose maybe 5 mg of morphine, oral morphine. Okay, then after 1.5 hours of the dose, patient suddenly telling, oh sir, you have make my day. Well, I don't know what you have make, like did magic, but really I'm not feeling any pain. So this is a alarming sign for you. If you are given only 1 dose and the patient suddenly telling you that the patient is not feeling any pain, so going ahead, if you do that same particular dose to the continuous every day, so the patient is in high risk of developing the side effects. So we need to reduce the dose. So excessive analgesia, apart from the expectation, can be a alarming sign for the healthcare provider. C means constipation. Morphine and weak opioid, weak or strong, whatever it is, opioids class of medication, it's a central acting drug, and it's reduced the bowel motility, and because of that patient develop constipation. And that's why whatever the patient, if the patient is like prescribed with any kind of opioids, patient should, there in the prescription there should be some bowel regimen. Okay, and preferably there should be stimulant laxative. R means respiratory depression. All of we are very fair about that. If we use the morphine or strong opioid or opioid, the patient may develop respiratory depression. We can say that, see, pain is like a sponge and your medicine is like a water. If you pour water in the sponge, it will absorb. Okay, so otherwise, if you are giving excessive water, the sponge will fall and then it will wet your floor. So that means there may be like respiratory depression and other side effect may develop. If we use the things as per the patient requirement, there is no respiratory depression. And if the patient is already from the previously patient is on the morphine or patient is on the opioid dose, we can continue without any hesitation. If the patient breathing pattern or respiratory rate is below 10, okay, on that time we need to take consideration if we are starting morphine for that particular patient. These are the things we need to keep in mind. U means euphoria. Euphoria is the excessive feeling of happiness or urinary retention. Okay. And M means meiosis or myoclonus. Meiosis is the pinpoint of the pupil of eyeball. Myoclonus, all of we know that myoclonus seizure. It's happening sometimes. So meiosis, whenever we check for the meiosis, we should not use the torch. Otherwise, we cannot recognize that it is because of the opioids or because of the torch, because you are putting torch to the patient people directly. So we need to check the patient's people in room light. Okay. And other than that, patient may have some skin rashes, patient may have some like nausea, vomiting as like universal symptoms. So these are the things patient may have. Next please. Okay. So communication, we need to have the proper communication to the patient and the family members, what is happening, how we are giving the medications, what is our expectation, why we are changing the medications. And of course, if we are sending the patient with strong opioid or opioid class medications and any of the SOS medications to the patient home, and we need to ask their family members, they should note it down that how many times they took that SOS medications and in which date, so that on the next visit we can recalculate the doses and give the like we can set the dose effectively. Next please. Thank you for your attentive listening, and if you have any query you can ask.
Thank you, Sudhi, for the wonderful presentation. Anybody have any doubts regarding this pain presentation? Please ask. Either you unmute yourself and talk, or put your questions in the chat box too.
Thank you, Kushum. Okay, Siva, by that time, if they have any questions, they can put it in the chat box. Can we move to the case presentation?
Okay, I think we can wait for a second and then we can move.
Thank you all, those who have told that it's excellent. Of course, if you need any study materials or anything, I can share the slide maybe, but of course, I can give you some study materials if you want.
So we will send the learning materials.
Okay,
soon,
okay. So maybe it's okay.
Along with your presentation.
Okay.
So, if you don't have any questions, we can move on to the case presentation. So Mr. Vishwajit will be presenting a patient story today. Mr. Vishwajit, over to you. In the meantime, if you have any questions, please put it in the chat box. We can discuss later on. Vishwajit, are you here? So can you hear me?
Hello.
Yeah, Vishwajit, yeah, we
Hello.
can yeah,
Yeah.
yes, we can hear us. Over to
Yeah.
you. Please proceed.
Hello.
Yes,
Yeah,
yes.
Yeah.
yeah.
Yeah. Very good afternoon to all.
Okay.
Myself, Bishwajit Das. So I am from Northeast Agartala, and recently I work in Patna with MSF. Here we are treated the advanced HIV patient. So from here I got one patient that I make a one case presentation that I will explain.
Okay. Go ahead.
Then one 36-year male patient come in our facility on 19 February 2020. So after coming here, the doctor diagnosed the patient had patient live with HIV with bacterial meningitis, then abdominal TB, then toxoplasmosis, and patient also at COVID-19 positive.
Okay.
Then about the past history, patient is a known case of HIV positive, known case of TB, history of smoking, no history of allergic to any drug, then arterial hypertension present. Date of HIV diagnosis, it was 16 July 2021. Then after diagnosis, the ART start is 2021. Then initially it start with TLD, and still patient is getting TLD drug.
Okay.
ERB adherence 10 by 10 as per patient statement. Then CD4 count was 56 when patient come in our facility on 19 February 2020. And the patient was on ATT, that 3FDC patient are taking from September 28, 2021, and no history of Kala Azar.
Okay.
Next slide, please. And after coming here, and doctor and nurses doing the physical examination. By the physical examination, we got the
Vishwajit, you can
Yeah.
just talk about the abnormal findings
Yeah.
in the physical examination.
Okay, sir. After coming here by physical examination, vitals also stable. Only the RBS was a little bit decreased. It was 76,
Okay.
and patient weight was also fine, and we find the edema present in the both leg,
Okay.
and the lymph node also not palpable, and we got the GCS score 15 by 15, and we got the pain score 7 out of 10.
Okay.
And next slide, please. And patient come in our facility with the complaint of leg pain and inability to walk since 1 month, loss of appetite 1 month, body swelling since 1 month, and loose stool since 1 month. These all are complaint we got when patient come in our facility. Next slide. Then treatment and significant investigation. So after coming here, we are started the treatment, diuretic treatment, sepsis and bacterial meningitis treated, dehydration management, and pain management. And also we are doing the basic investigation after coming in our facility, that is CD4 count and HIV viral load, gene expert, RK39, that all RK39 Kala Azar test was negative. Then cryptococcal meningitis also negative, hemoglobin also fine, platelet also is normal, blood group was O positive, blood urea creatinine also fine, SGOT, SGPT also fine. Then total bilirubin was 1.5, and direct bilirubin it was 0.5, and serum potassium it was 3.3, and sodium was 116. That patient had hyponatremia.
Mm.
Next slide. The medication. First medication we are giving to the patient, that is ceftriaxone, that actually we given for the meningitis treatment. That 2 gram start, then 1 gram BD for 7 days, then albendazole start. Excuse me. That medication slides. Yeah.
Yes, yes.
Then TLD drug, that ARB drug, patient are getting the OD daily basic. Then for pain, tramadol 50 mg TID initially started, then it was 50 mg SOS. Then metronidazole 400 mg TID for 5 days. Then cotrimoxazole 440 mg OD as a prophylaxis treatment. Then omeprazole, furosemide for diuretic, and 3-FDC for TB management. Then ORS also we are given for 2 sachet per day. Then PCM also SOS for pain and fever, and loperamide for loose stool.
Okay.
Then psychosocial aspect, that patient wife also HIV positive, looking upset and scary due to HIV, needs support to the daily routine. As he is COVID positive, so we cannot allow caregiver to the patient side. So mentally stressed and related to disease condition. Then sometimes patient feel the loneliness due to isolation because patient had COVID positive. Then social support and training for COVID-19, individual session involving play therapy and cognitive behavior therapy to increase the patient's self-esteem. Then health education to patient wife about HIV as well as COVID. The focus on the individual rather than the level of HIV. And the plan of discharge, we are doing telephonic follow-up and the home visit. Next slide. The main concern is advanced HIV with poor adherence with severe immunosuppression, then generalized weakness, loss of appetite, loose stools, hyponatremia, dehydration, and psychosocial stressor, and COVID-19.
Okay.
Then the summary, monitoring of blood glucose level in our facilities every 4th hourly. Then initially we started, then it was every 6 hourly. Daily monitoring of IO charting because patient had swelling in both leg, and also diuretic we are given. Vitals every 4th hourly. Daily pain and unconscious checklist. Then aspiration, AROA, the personal hygiene monitoring tools, etc. Daily follow-up, daily weight and MOAC we are taken from patient side. Weekly discussion during multidisciplinary team meeting, expert with nurses, HPT and mental health. Weekly PPS and ESS and mental health checklist on daily basis. Still this patient is with us, and patient improved, lot of ambulation improved. Patient has reported to the treatment and clinically shown improvement. Now she understands the need for proper nutrition and good adherence. Then the discussion point, education about COVID-19, preventive measure to patient and attendant, teaching regarding care of patient at home, to contract the government scheme providing the financial aids for HIV patient, to ensure access to ART drug by connecting her with the respected ASHA worker in their local area.
Okay.
And
Thank you, Vishwajit, for the presentation. If anybody have any questions or any clarification regarding this patient story, please ask to
Somebody
Vishwajit.
raised hand.
Yes, Hadia, do you have any questions?
Okay, so do you want to ask the group, Shiva?
Yes, we can ask the group.
So from the group, there anyone who can just contribute some of the things from the issue? Okay, so I think we need to discuss. Can you just maybe only okay, like, can you just share the slide again, the discussion part?
Yes.
Yeah, Antonia is there. She wants to.
No, that, yeah,
She raised hand.
she wants to know about the abbreviation of TPS and the ESAS.
She wants to know.
Yes, Vishwajit.
Vishwajit, the term, I think.
that PPS means palliative
Performance scale.
palliative performance scale that we are
Yes.
doing here.
Yes. So it's like, so I'll just try to contribute in the palliative performance scale. There is, it will give you the like patient overall, overall patient, like how the patient is doing. Okay. It will give you um, a picture regarding your patient, how like patient is or altered sensorium, or patient can take food, patient is movable, patient can take his daily living activities or not. So overall there is a palliative performance scale. Request you to please go through. It's already in the like, if you see, it's available in the net also. So just go to the discussion slide, last slide, last.
Sudeep, they need more clarification. They need to understand about TLD, CD4, ATT, ART.
So basically CD4 cell, it's reduced because of HIV. No, it's reduced in HIV. So CD4 monitoring, basically it's required, where you can understand the how much the ART treatment is effective for the particular patient. So if you are giving ART treatment, antiretroviral treatment to the patient, so CD4 T cell, it's like you need to monitor, keep on monitoring. So see how much the CD4 increasing, it will show the effectiveness of the treatment. Okay, because it's damage the CD4 cell. Any other thing?
Oh, no, good.
Okay. So like first question, first discussion matter is education about the COVID-19 prevention matter to the patient and the attendants. Of course, you need to maintain the good communication skills with the patient and the family member. So from the history, we come to know that patient family members, that the patient's wife also having that HIV positive. So here, that one thing need to keep in mind, that who are there in the other members of the family and the neighbor and the close relatives who can take care of this patient. Okay, so education is required for them, and their understanding level, you have to give the health education to the patient, and in their language, and in their preferred language, and in the level of their uh, level of understanding. Next, teaching regarding care of the patient at home. So whenever you are going for the home visit for the particular patient that you told there that in the home care you are planning for the particular patient, what are the things they need to keep in mind? Like simple things, the patient is having swelling in the limb, so how to take care of the lymphedema, and then you need to demonstrate this. Second thing, if the patient is having pain, whether the patient is taking the medications, and if there is SOS medication, how many SOS medication is going, and do they maintain any of the like, right, I have told in my lecture that they need to ask to maintain a record, so how many SOS dose they have taken, and along with that, that like if there is no pain also, do the patient relative asking every day that the patient is, whether the patient is having pain or not. Third question is to connect with government scheme providing financial aid for the HIV patient. Of course, you can take the help from the like social worker or um, medical social worker who are the expert to explain those things and who will help them out. And like ensure the access of ART drug nearest center, and you can really connect to the local GP or maybe the ASHA worker to follow up and the reach to the patient, so that they will be getting all the facilities in their doorstep. Because the family, in the family, if the patient and the family patient wife is there, only both of them they are there, and they are both of them they are HIV positive, we need to take the patient, this family is consideration, and who are the person and local volunteers, we need to keep them in the uh, loop so that we can help them out. There are some questions from the some participants, so I think Vishwajit is the person who can give the answer. Some short from no, they wanted to know.
Sir, one question I got that TLD full form. So TLD full form is, this is ARV drug, tenofovir, limobodin, and dolutegravir. The dose is 300 and 50. Dolutegravir is 50. That is mostly we are given to HIV patient, that OD.
Okay,
And
so okay, Shiba, can I proceed?
Yes, you can.
Yes. So here, as the discussion was on pain, so I like to ask to the group. So do you think that as a nurse, what are the things you should do for this particular patient from the pain perspective? You can put your answer in the chat box.
Good evening, sir.
Yes,
Hello?
good evening.
Sir, we can do like complete pain assessment for this patient, because
Of course,
pain
yes.
is not numerical value actually. It's beyond
Okay.
numerical values. Some
Okay.
physical, social pain can patient have, and psychological aspect, like because one he is HIV positive, another he is COVID, means like two kind of devastating condition he is suffering.
Condition. Yes. Yes.
He is suffering. So we have to take like comprehensive assessment like OPQRST for this patient, like what kind of pain that have, and we should monitor it. We should monitor it like a vital, like morning, evening, night. Every shift we have to check. That's
Okay.
part I think we should taken care of.
Thank you, Kusum, for your contribution. Just I like to add few points that if as you have seen that in the scenario, no, that firstly the patient was suffering from pain, but going ahead there was no pain. So if you are assessing in PQRST format, you may not get in any like pain or like the patient is suffering from pain or any other things. But in such condition, just go to the just little bit. Of course, you are in the track, that we need to like explore the patient family members. Like if both of them they are there and both of them they are HIV positive, and now the husband is having COVID-19, and the wife is, of course, she is not allowed to go inside, and she cannot see her husband also. In such condition, the other three aspects, the psychological, social, and spiritual, these aspects we need to emphasize more, so that the other things related to those three issues can come out, and we can help them out in the support of our multidisciplinary or interdisciplinary team as well. Any other? Shiba, I think you can just stop the screen share so that we can
Yeah.
see all of them. Yes, it should be open discussion.
Okay.
Okay. So other participants, do you have any anything to say? You can share.
Comments I can. Jomi Chaco?
Yeah.
Yeah.
Hello. Yeah, myself, Jomi. I just want to give some of the questions raised in the chat box. So one is regarding that PPS score. That is one of the monitoring tool that we are using in our facility. So PPS is basically palliative performance scale. So there is certain parameters are there in the PPS score. So the first one is regarding the patient ambulation, and
Yes.
second one is regarding the patient activity level, and third one is regarding the self-care, whether the patient is able to do alone self-care or not, and third one is how the patient is taking the intake, and fourth one is the consciousness. So all these parameter, based on this parameter, we are giving the percentage. So 100% is the maximum. That means patients are doing quite good. But if the percentage is going down, the patient is not doing good. So suppose in our facility, in advanced HIV facility, so we are getting so many patients with PPS score 30%, 20%, something like that. So we can assess where we are actually. So it will be good if you do the PPS score on a weekly basis. Then we know how the patient is, where is the patient
Improving
is going,
or-
whether patient is
Yes.
deteriorating or patient is improving or not.
Yes.
So yeah, second question raised in the score is regarding ESA score. That is also another kind of tool that we are using in our facility. That is Edmonds Syndrome Assessment System. In that also there is certain parameters that include pain, and second is tiredness, and third is drowsiness and nausea, shortness, depression, and anxiety. So all these parameter we are giving the score same like the pain score, like 1 to 10, and so accordingly we will put the score. So after 1 day or 2 day, if you want to assess the patient whether patient is improving or deteriorating, look at the previous score and compare the score with today. So by that we can assess the score, assess the patient improvement actually. So these are the two monitoring tools that we are using in our facility. And ATT, everyone knows, I think it's already answered also, anti-tubercular treatment, and ART is antiretroviral treatment, and this is a fixed dose thing, and usually these patients are the case presentation patients are taking the 3-FDC. That include isoniazid, pyrazinamide, and rifampicin. That is a tubercular treatment, I think. Yeah, that's it. Thank you.
Thank you. And in the ESAs, no, there is most probably the total 8 symptoms covered.
Yeah.
Total 8 symptoms. Yeah.
So it will be just adding one more thing. It will be good if it is a palliative prospective, then it will be good to assess all these score at the time of arrival, and then depends on you can evaluate either it is daily basis or weekly basis. And so in our facility, what we are doing that we are taking all these parameter at the time of admission as a baseline data. Then we are doing on weekly basis. So this score will also, we will discuss in the multidisciplinary team meeting also. By that, we can plan for the patient for the upcoming weeks actually, in terms of whether we need to increase the analgesic or any kind of drugs we can do. Yeah.
Okay. In the chat box, there are two questions. One was regarding the morphine titrations related something. So basically the morphine titration, it is the, of course, we need to, as a nurse, we need to assess and we need to anticipate the things if the patient is suffering, so that our physician will do the things properly. And if not, if the treatment and if the doses is not effective, again we can emphasize the things so that the patient address issue should be addressed properly. Second thing, second some issue, one questions arise, if the patient is cognitively impaired, so what to do? So basically in such condition there is you have to see the RAS scale, okay, RAAS scale, RAAS scale, where if the patient is cognition level is below -1, then the patient will be considered as cognitively impaired, and that time Dolo plus 2, one scale is there, Dolo plus 2. Dolo plus 2 can be effective, but in some cases PEG scale, PACLASLAC, there is some scale, so both the scale is most effective. So but so many things required for that, the nurses has to be empowered enough to use those scales, otherwise it will give the wrong impact or wrong outcome. So we have to practice more, and if we we do not have the nurses like that, so we should not use those things in the setup for the misleading actually. But there are some scales which can be used for cognitively impaired patient, but we need the expert enough. Okay.
Sudeep, I want to add few things. Regarding one question from Antonia, said the nurses can take history, or it is only the doctor to document this. Of course, in palliative care, nurses will be doing the assessment part, and nurses will be documented. So based on the documentation, doctor will be prescribing the drugs. Sometimes the doctor will be cross-checking whether the patient is having the same pain or not. So otherwise, based on the nurse's documentation, they will go for the management part. And one more question, whether the nurse can titrate the morphine dose or not. So of course, we are, as nurses, we are not an authorized persons for prescribing drugs, but we can increase the dose because as per the doctor's order. So at least you have to, if the patient is not get adequate pain relief with a particular dose of morphine, you just make a call to the particular doctor whom the morphine is prescribed before. So you have to contact as telephonic conversation with the doctor. You have to document it as advised by doctor so and so. It is increasing, so that we can increase the dose. That the patient is not get adequate pain relief with 10 milligram morphine. So as advised by doctor so and so, that morphine dosage is increasing from 10 milligram to 50 milligram. So we have to document it properly.
Yeah, I wanted to just add few things in that. So basically, things happen that verbal order. So every institute have some policy on verbal order, no? So sometimes the situation not permitted that doctor is busy in some certain situations, and we need to give the medication. So we follow the verbal order. So verbal order need to be clear twice, and it has to be cross-checked. And second thing, within 24 hours or maybe 12 hours, the doctor has to put it physically in the prescription. And second thing, for the titration part, Of course, if the doctor is prescribing any of the opioid or pain relieving drugs, there is some SOS drugs. So if the patient is getting more SOS or very frequently than the expected, like okay, in a day maybe 1 or 2 SOS dose maybe okay, but patient is taking since last 6 hours, patient took total 4 number of SOS medication. So it is little bit worried that patient is not having the adequate pain relief. So in such condition, we need to emphasize the things. We need to escalate the things to the our physician. This is the thing. Yes, Siva, sorry, actually I just make you stop. So if you want to share, go ahead.
So I just check whether there is any more questions in the chat box.
Actually, in my mobile, no, I cannot check all the things.
Yes, we'll check it. So if we want to assess pain for unconscious patient, we can use BPS. So, okay.
Somebody has raised Alina ji.
Yes, Ali. Please unmute yourself and talk. Ali, we can't hear you. Ali, please unmute yourself and talk.
Okay, those who have any query, you can just email. So maybe we can give them the clarification. No?
Okay. Thank you.
Anything else?
No, I think so. Before we wind up the session, I would like to highlight few things along with the Sudeep presentation. So as we understand what is pain, and in palliative care we have a lot of patient in pain in all settings. Obviously, we have seen a lot of patients in pain. As nurses, we should keep it in mind. Pain is what the patient says hurts. We believe the patient words. That is very, very important. So after that, you have to do the proper assessment as the Sudeep was discussed it earlier. You can use PQRST scale and or you can add SDPQRST scale, site, duration of pain. P is provocating and or palliative care factors. And Q is quality of pain. R is radiating, whether the pain is radiating to from one side to another side, and severity, how to use numerical pain rating scale, 0 to 10 scale. So based on the scale, they will tell one score. Based on the severity of this, the pain, you have to treat. And the last one is temporal factors and time and temporal factors. So and another thing is, and we have discussed about the types of pain. Mainly we have seen in palliative care, we have seen 2 different types of pain: nociceptive pain and neuropathic pain. So nociceptive pain, we all know that associated with the tissue injury, and neuropathic pain is the patient is having neurodermatomal distribution also. The features like allodynia. So I don't know how many of you heard about that word allodynia. Pain sensation that patient when touched. If there is a small touch, the patient sense pain. So that is allodynia. That is the main feature of neuropathic pain. So this is very, very important. We have to assess it well. Proper assessment is enough for the effective management. So you have to do the proper assessment, and you can after assessment you have to do the, that mention the body chart. In palliative care, we are using the body chart too. So you have to highlight the pain areas where the patient's pain and all. So so yeah, maybe later next week we have a session on management part pain. same thing. That time we will discuss more about that. These are the important points you need to keep it in mind when a patient comes to you with a pain. So definitely you have all keep it in mind. Again, I'm saying you have to believe the patient words. Okay. We can wind up the sessions. Thank you, Sudeep, for the wonderful presentation. Thank you, Vishwajit, for a case presentation. We can see you in the next week. Thank you for asking your doubts and all. Anyway, we'll meet you in the next week. The management of pain, part 1.
Thank you, Tips, for giving me that opportunity to be part of your echo session. And thank you all. Thank you all the participants for your patience listening.
Thank you.